Thank you. Good morning. Go Bruins. Great pleasure to be here. And I'm going to talk to you about the entire IMPACT program, which I think is about to have an impact on our practices. And it's good for everyone to catch up to where things stand. Here are my disclosures. This is the treatment of stimulating the sphenopalatine ganglion, which, to refresh your memory, is a cluster of 60,000 neurons, 3 millimeters in size, at the back of the maxillary sinus, and is where the parasympathetic output synapses on its way to control the vasculature of the anterior circulation. Stimulating the SPG is a potent collateral enhancement, leads to cerebral vasodilatation as a major impact. In addition, there are suggestions that stimulating the SPG also stabilizes the blood-brain barrier, may have direct acute neuroprotective effects, and may have longer-term neuroplasticity enhancement effects. So it is an attractive target for a neuromodulatory approach to treating acute stroke. In preclinical animal models, it immediately dilates ipsilateral blood vessels, reduces infarct size, and stabilizes the blood-brain barrier. And so the devices have been developed for SPG stimulation. Here's the BrainsGate device tested in the IMPACT program. It's a small little toothpick size electrode that's inserted at the back of the soft palate with this insertion device under CT guidance, done primarily by neurologists in these trials. Skin-to-skin time now of 4 minutes with the new bite plate technique that's available. So a potential new intervention for interventional neurologists coming. The IMPACT program has so far consisted of 5 clinical trials, including feasibility trials, pilot and pivotal randomized trials, and then expansion and mechanism of action trials. And although these studies have been going on for 12 years, the results of the first 4 now completed were all published this year, including in Stroke and in Lancet. The latest, IMPACT-M, published this week online in Stroke. And IMPACT-P is continuing to recruit. So there's a lot of information to absorb all at once from a very extensive development program. Here are all the publications. Let me just highlight key take-home messages from the big randomized trials and the latest mechanism of action trial. So the pivotal trial was IMPACT-24B, a randomized trial, 1,000-patient trial, the largest device trial ever done for acute ischemic stroke. Patients enrolled up to 24 hours of onset, 8 to 24 hours after onset, could not be thrombolytic candidates and could not be eligible for a thrombectomy in their place of practice. And NIH stroke scale of 7 to 18. We had 2 primary populations, all enrolled patients, but also the subgroup with confirmed cortical ischemia by having an aspects abnormality in a cortical region and NIH stroke scale greater than 10. Those were co-primary populations. That meant we needed either both to be positive at under 0.05 or one to be positive at under 0.025 to declare success. And the otherwise pretty broad enrollment criteria. All you needed was a CT scan to get in, no required vessel imaging or perfusion imaging. Patient's treatment was started within 8 to 24 hours of onset with 4-hour stimulation on day 1, and then daily 4 hours of stimulation till day 5 when the electrode was pulled and outcome imaging was obtained, and final outcome at 90 days. Populations well balanced between the sham and active treated groups. And here are the results from the pivotal trial within the all-comers primary population. There was differences that did not reach statistical significance, but in the confirmed cortical ischemia primary population, for the primary endpoint of a favorable ranking outcome at 3 months, sliding dichotomy, the p-value was 0.0258. There was a 10% increase in the number of people with a favorable outcome at 3 months. That is as close as you can come to a positive trial, 0.0258 rather than 0.25 without it being formally positive, but strongly suggestive, and a lot of additional evidence indicating this is a genuine effect. All of the other efficacy endpoints that were pre-specified as shown here also showed strong indications of benefit. And when we added in the patients from the prior 250 patient pilot trial and did a pooled individual patient analysis, now you can see that in the confirmed cortical ischemia group, this 10 or 11% increase in favorable outcomes has a p-value of 0.004. In addition, there was a strong dose-response effect that when the electrical stimulation that was delivered was in a low to middle range, which is the best driving range for the SPG, then we had a much better increase in outcomes over control, and the p-values indicating the presence of a dose response highly significant, and clinical trialists recognize that dose response curves are very hard to generate by play of chance. It is a very strong supportive finding. If you look in the sweet spot of the patients who were in the quarter of the dose response range that was most favorable, very strong benefits of therapy. So positive group of results leading to this authorized Lancet statement of cumulative evidence indicating that for confirmed cortical ischemia, the treatment reduces stroke disability. Let me show you the latest hot off the press this week in stroke, Impact 24M, which was done to improve the delivery technique, but also to look at immediate effects on blood flow and function. And during stimulation in this 50-patient trial, the blood flow through the common carotid artery was increased 44% during stimulation, and the patient's hand function, grasp, and pinch strength also increased substantially during stimulation. So there's immediate effects on blood flow and neural function, as well as improved 3-month outcomes. We have launched a couple months ago Impact P, which is looking at in patients headed for thrombectomy, can the treatment preserve penumbra by collateral reperfusion and deliver more salvageable brain to thrombectomy as a bridging therapy. So overall, a very strong device set of evidence that is now being submitted to FDA for first clearance in the US and to EMA for CE mark of the latest device, CE mark of earlier devices that were in market already available there. This may be in your hands in 6 to 18 months as a new therapy for acute ischemic stroke. And I'm hopeful that the IMPACT program will have an impact on our practice. Thanks very much for your attention.